Hi, Scott Tanner. I'm looking to get a breast augmentations. Do you mind going through with me the different types of implants that you offer?
So there's multiple different types of implants, and when we look at implants we break it down into sort of 5 or 6 different S's. So first thing we look at is the shape of the implant. The implants can typically either a round implant where the width and the height's the same, and then you can adjust the different projection of the implants, and that's how we adjust the volume. Or they can be an anatomical shaped or teardrop type implant where the top's more natural compared to a round one, and there's a lot more volume at the bottom. And with teardrop ones or anatomical implants, we can adjust the width, the height and the projection differently, so we have a bit more variability with a teardrop implant. Then when we look at implants, we look at the substance of the implants. Implants can typically contain silicone or they contain saline. So saline implants used to be used a lot, especially when I was concerned about the safety of silicone. But now we almost universally use a silicone gel implant. And the gel inside the implant, depending on whether or not it's a round implant or a shaped implant, has got different cohesivity, so depending on how viscous the gel is. So on some of the rounder implants, they're a really soft gel, so they feel quite natural. And then with the more anatomical shaped implants, they're a bit of a firmer gel. And it's almost like a Turkish delight. If you cut these in half and squeeze them, the liquid doesn't run anywhere compared to older gel implants. So if there is ever a rupture, they don't leak to the glands in your armpit like the older implants. Then when we look at the implants, we look at the shell of the implant. So implants can either be what typically called smooth, or it's a smooth silicone implant, or it can be textured, where the implant's a little bit roughened. And the roughened implants were invented really to minimise what we call capsular contracture, the hardening around an implant. And there's different types of texturing from the different brands, and they have slight pros and cons between them. And then you have what we call polyurethane implants, which are basically a smooth implant with a polyurethane coating vulcanised on the surface of the implant. And these are really used to minimise capsular contracture, and they're very grippy, so once you put them in, they don't move or rotate. But that polyurethane coating is degraded by the body over about 5 years and then becomes a smooth implant again.
I was wondering about scarring, whereabouts we're going to do the insert, if it's going to be under the muscle or above, and whereabouts the scars would be.
So then we look at implants, where we put the implants. So we can put implants in on top of the muscle or below the muscle, or a combination of what we call dual plane. And we go through, and there's pros and cons why we choose one over the other. And a lot of it's got to do with your soft tissue coverage over your chest and the volume of your breast tissue. Looking at your breast anatomy, do you have a very natural breast shape, or do you have like a breast anomaly, like a tuberous breast? Or if you've got a little bit of breastosis where your breast has dropped a little bit, you need a little bit more lift. And we can go through that when we do the examination. And then with scar, where do we place the implants? So there's 3 typical locations that we put an implant into the breast. Is either through the inframammary fold, so the breast crease, around the areola, or through the armpit. Almost universally now we put an implant through the inframammary fold, the breast crease. And this comes back to the incisions around the areola. With the more form-stable gel implants, because they're not compressible like old saline implants, you need a slightly longer incision, about 4.5 to 5 centimetres. With the old saline implants, you could put them through a small 2 or 3 centimetre implant. But with modern implants, because you need a slightly longer incision, most people's areola isn't big enough to put an implant through there. Also, the areola in the nipple is an area on the breast where there's lots of bacteria. So we prefer not to use that site because there's an increased risk of contamination of the implant when you put it in, and that increases your risk of capsular contracture. So using the inframammary fold or the breast crease, it's a much cleaner site and has a lower risk of revision. Same with the armpit. The armpit is full of bacteria and it's at a high risk of contamination during implant insertion. And you can't use a shaped implant when you put it through an armpit because you can't control the rotation of an implant when you put it in. So they're a few of the sort of basic points that we go through when we select different implants.
My last question is, I was just wondering about breastfeeding, because I'm looking to have children in the next few years, and I was wondering how I'll go with breastfeeding with implants in.
Yeah, so with breast implants shouldn't interfere with breastfeeding. When we put an implant, even if you put the implant on top of the muscle or below the muscle, we're not interfering with basically the nipple areola complex and the gland. So the innervation to the breast gland and the nipple is intact, so your ability to breastfeed should be the same. What we don't know is how responsive your breast tissue will be to when you're pregnant and you breastfeed. So some people can have a small breast, they breastfeed and the breasts become quite large and their skin doesn't tolerate it and they stretch. So if you have an implant in, you might be more likely to have breastosis after breastfeeding with an implant than if you did not have a breast implant. Also, some people can have a C-cup breast and aren't able to breastfeed and their breasts aren't overly responsive and so they don't get any stretching. So there's a little bit of unpredictability if you have especially a bigger implant and then you breastfeed, you might stretch your skin more and then have a high risk that you might need a lift in the future that you may not have needed if you didn't have a breast implant. Also, when going forward, over time, we know probably about 50% of women by 10 years need some form of revision. Whether it's because they're breastfed and the breasts have dropped, or they want bigger implants, smaller implants, they've had a complication such as capsular contracture. So most people have another procedure at some stage in their life. By 10 to 15 years, over 50% will have some procedure, but it's almost 100% you'll have another procedure at some stage in your life with a breast implant.